here you can see the intestinal or gastric mucosa with pits appear like this. The central dot will be the pit and surrounded by circular capillary pattern. This is the normal pattern. So, if you see, you can find similar findings in Barrett's esophagus also. Based on this, there is a Nottingham's classification where if the pits are round with regular vasculature, it is normal, no dysplasia. You need not biopsy it once it is diagnosed. And if the same pits are distorted with irregular vasculature, you are sure that it has high-grade dysplasia. You can go for biopsy or resection. For example, this is a normal Barrett's. You see the pit pattern is regular and microvasculature is regular, so no dysplasia. In another image, if you have this irregular pit pattern and irregular microvascular, you can say even without biopsy that this has dysplasia. So, such high-grade dysplasia requires treatment, endoscopic treatment. In the esophagus, there is no pits. So, esophagus, there are papillas. So, if you see esophageal mucosa on a image-enhanced endoscopy, you find these structures like submucosal vessels, and there will be small capillaries forming a loops. These are called intraepithelial capillary loops. In short, IPCL. So, unlike in gastric and colonic mucosa, where we use both mucosal surface pattern and vascular structures to know whether there is dysplasia or not, in esophagus, we depend only on the vascular pattern to say whether it is normal or abnormal mucosa. So, this is a normal mucosa. You can see the small capillaries forming the loops, and they are regular, thin, normal. And in the background, you can see dark green submucosal veins. These are the. So, when there is a dysplasia from the normal, there is an evolution of mucosa from the normal to abnormal. These capillary loops undergo dilatation, tortuosity, and also increase in size, become irregular. These four characteristics are used to define if there is any neoplasia or not. So, as there is progression of the mucosal carcinoma, the characteristics of these capillaries change, and these can be used to diagnose it. So, the Japanese Endoscopic Societies use this AB classification for the diagnosis of esophageal squamous cell carcinoma. So, A is non-neoplastic, so the loops are regular. If the loops becomes dilated, it's B1. If it's become irregular, it is B2, and B3 if the dilatation is more than 4 times. For example, see here, compared to normal, these loops are short, irregular. So, it is a neoplastic, and if you are able to see these dilated vessels, compared to loops, these vessels are more than 3 times dilated, then it becomes a malignant. So, other evolving and emerging research studies were going on in confocal microscope, where you can assess the mucosa in vivo, but these are more for research purposes, not used in regular thing. And one more such thing is optical coherence tomography. It's like ultrasound. In ultrasound, we use ultrasonic waves to assess the structure of a structure, whereas here we use this. And also AI is going to help in esophageal cancer detection. We already have this in colon, and in esophageal it is coming. Just coming to staging, staging is important because it alters our management. So, first of all, if your endoscopy, if it is small lesion, no suspicion for locally advanced, then you assess if it is resectable or not. If it is like large, if suspend local advancement, then do a EUS and look for any submucosal invasion. If there is submucosal invasion, it goes to MDT. If there is no submucosal invasion, then you can attempt for endoscopic resection. This is the reason why you need to stage the disease prior. In US, if there are no metastases on integrated PET-CT, you go for US for local regional staging, because US has more sensitivity in detecting the regional metastasis, nodal metastasis, especially celiac nodes and other regional nodes. So in EUS, we find various structures. We can see the 5 layers in detail. And another important thing is we need to know in early superficial cancers, like superficial esophageal cancers, whether it is limited to the mucosa or submucosa. But US has a limited role in this. US has role only in the loco-regional evaluation. For T1, TIS versus T1, US has limited role. So whenever in US, if you see that it is only limited to mucosa, then you can attempt an endoscopic resection, which my senior colleague will be discussing. So in concluding, we need to detect early cancers. There comes this role of this endoscopic assessment. So take time. We should take time, use the best possible endoscope, inspect carefully, look for any subtle changes. Always use imaged enhanced endoscopy, biopsy if doubt. If endoscopically resectable, resect. Summarizing, endoscopy with biopsies is the gold standard in diagnosis, and image enhanced endoscopy with AI will be the future of detection and diagnosis, and EUS has a definite role in loco-regional staging. Thank you.